Okay, just start. Just
Okay,
introduction, and sir
okay,
will
sir.
proceed
Okay,
for the Sitaji.
okay,
Okay.
sir. I'm audible, sir.
Yes, yes.
Yes, it
Audible,
is.
dear.
Yes, it is.
Yes, sir.
Good evening, doctor, and all. I am happy to introduce the Dr. Devan Sansania, sir, diabetology at hospital base at Rajkot. And Dr. Devan Sansania, sir, is a specialty in the diabetic treatment. And today, Dr. Sir, Devan, sir, explain to your risk and the screening of the diabetic in drugs, like and the native patient with the comorbidity. And cleanly request to all, if any query in this session, so drop your question in this comment box. And now session over to your doctor. Sir, please the request to proceed.
Yeah,
Yes, sir.
so yeah, thank you very much, Hitesh, for your kind introductions. And good evening, everyone, for your patience hearing. So today I'm going to talk on the very important combinations on, I would say, the decoding the complication of type D and patient case-based approach. So in the upcoming slides, I'm going to focus on the very most important points only. Uh, we won't waste much time, and we straight away focus on the very important points which can help in our practice in day-to-day practice. So when I say next slide, so you just change the slide. So this is the current state of diabetes in India. There's, we all know it is increasing. Next slide. So even the 2026 guidelines ADA has recommended the use of SGLT20 inhibitor in most of the patients. So the guidelines are now very specific actually. Instead of just stepping up approach, one must focus on the very important points, whether there is a severe risk factor, whether there is a heart failure, whether we want to reduce the weight. So based on all these parameters, we should choose the anti-diabetic agent. So that is the guidelines which has been happening since almost like 22, 23, 24, and even in the 2026. Now the guidelines are very much specific. Use the molecule based on the patient's factor. Next slide. Even our RSS guidelines also recommend the ABCDEF approach. So there also DPP4, SGLT2 inhibitors, metformins are very well placed in the different profile of type 2 diabetic patients. Next slide. So there is a strong utility, as we all know that. So if we talk about the monotherapy to dual and triple, so this is how actually they recommend to use the triple therapy when the A1C is more than 9 or more than 8, or our patient is not on the target. Still, the A1C is more than 1.5 from the target. So we should go for the triple therapy also. Next slide. So this is a very important slide. So now how these SGLT2 and DPP4 combinations can provide up to 1.5% reduction of A1C with less risk of hypoglycemia. So this is a very important factor. So I would say this is one of the most important slide. So these are the class of the anti-diabetic as drugs, like we have SGLT2 inhibitor, we have DPP4, we have sulfonylureas, GLP-1, and insulin. So these are the parameters that we should focus. Like we want to reduce the A1C, we also want to prevent the beta cell exhaustion, we also want to prevent the hypoglycemia, and we also want an agent which is weight neutral or also the agent which promote the weight reduction. We want an agent which reduces the blood pressure and also gives the cardiorenal protection, and also which is a very convenient route, which is the oral route, and also the affordable cost. So these are the very important parameters that we always keep in mind while prescribing the anti-diabetic medicines. So these combinations, if we talk about the SGLT2 plus DPP4 combinations, gives the most benefits. High efficacy, establish cardiac event, giving the protection, having a pleiotropic benefits. So all those are very important parameters that we should keep in mind. Next slide. Start early there, yes, we all know that. Now come to the sitagliptin and DAPA combination. So there is a very strong clinical evidence because of the uncontrolled type 2 with heart failure, with high severe risk patients. So dapagliflozin 10 milligram plus sitagliptin 100 milligram once a day tablet only. and it is actually contraindicated when the eGFR is less than 45, and evaluate the renal function before initiation and monitor periodically. Next slide. So we must use the individualized approach in type 2 diabetic patients. So as just I discussed in the previous slide, individualized approach is very important. You look at the age, you look at the parameters, you look at the weight factors, you look at the associated any severe risk factors are there or not, like blood pressure, dyslipidemia. So I would say 84% of the Indian type 2 diabetic patients have more than or equal one comorbid condition. So yeah, this is very true actually. In our even day-to-day practice, when we see our patients, we often see associated hypertensions or associated high cholesterolemia or maybe at least obesity. So we often see this kind of risk factors in type 2 diabetic patients. Next slide. So united by glycemic equal risk factor. Next slide. So yeah, this is again a case-based approach. A 64-year old, this is hypothetical case, and we should rather focus on the discussion part. 64 years male patient, retired accountant, having a type 2 diabetes since almost 12 years, uncontrolled on metformin, and also hypertension since 10 years on ARB with ischemic heart disease diagnosed 3 years ago. EGFR is mildly like on currently on stage 2 CKD. That means the EGFR is 62. Uh, Symptoms: dyspnea on exertion, frequent urination, fatigue, BMI is a bit high, I would say, in an overweight condition. So these are the parameters on the right hand side. You can see the FPG is 174, PPG is 244, and A1C is 8.8%. So he is uncontrolled type 2 diabetic patient with established cardiovascular disease and early nephropathy as well. So how should we treat these kind of patients in our practice? So let's discuss that part. Next slide. Yeah, so therapeutic consideration that as we just discussed in the previous slide, we should focus on the parameters and what we actually initiated the treatment. So he was on metformin only, and what we initiated in these cases, we started with the dapagliflozin plus sitagliptin 100 milligram once a day to reduce the glycemic burden, to preserve the renal function as well. So just by adding these combinations at the end of the 16th week, we show a good reduction in A1C level from almost 8.6 to 6.8%. Fasting came down to 120 and PPG came to 160. Weight also reduced as he was a little overweight. Blood pressure also gets better, as we all know that SGLT2 inhibitor having a slight effect on blood pressure as well. EGFR also gets stable and ESCR also gets better. So what are the outcomes that we observed with the sitagliptin plus dapagliflozin combination? So it achieved the A1C target, improved the renal and CV markers, also reduce the weight, safe in elderly, reduces the heart risk also, and also good tolerable, and also giving a good adherence as well. Next slide. So in Indian setting, this combination is well actually positioned. In the Indian context, SGLT2 plus DPP4 is a preferred combination for type 2 diabetic patients with high HbA1c, CV, or renal risk factors, where weight loss and hypoglycemia prevention are also priorities. So just I discussed in the one slide that I talked about that, which is a very important slide. So parameters we should always keep in mind while tailoring the anti-diabetic therapy, and this combination is very well positioned in this our type 2 diabetic patients. Next slide. So again, second case for the early cardiorenal risk management. So 58 years old, having a retail shop owner, type 2 diabetic patient since almost 8 years, hypertension for 6 years, control on ACE inhibitor. Recent lab showed persistent microalbuminuria, fatigue, frequent urination. These were the symptoms. BMI is 29, which is very close to obesity range. In EGFR is 63. Fasting 168, PPG 239, 8.7 A1C, and also having a microalbuminuria. So under control on type 2 with early diabetic nephropathy as well as increased cardiovascular risk factor. So how should we approach this kind of patient? Next slide. Next slide. So again, In this kind of patients, we again use the triple drug combinations, like along with the metformin. So, which is a dapagliflozin 10 milligram, sitagliptin 100 milligram, and metformin 1000 milligram. So, this is a very excellent combination, I would say, because it almost covers the most of the ominous octet pathogenesis of type 2 diabetic patients, where it out of eight, almost six pathogenesis factors are actually treated with this combination. So by just having this triple drug combination, which is a metformin 1000, sitagliptin 100 milligram, and dapagliflozin 10 milligram. So by just having these combinations in this once a day preparation, at the end of 16 week, we saw a good reduction in A1C level, fasting level, PPG level, as well as the weight. So all the parameters are actually improved after the end of 16 weeks, I would say. Achieve the glycemic target, improve the renal and CV markers, also blood pressure reduced, no hypoglycemia, all these factors are getting better. So, as I discussed, it almost addresses this ominous octet when we use these combinations. So, very well, I would say, very synergistic actions of each and every drugs, which gives a very good reduction in A1C level. Next slide. Yeah, so these are the points that we just recovered. So this is why this is a synergistic effect of this combination. So net effects are reduces the hypoglycemia, reduces the weight, blood pressure, and also metformin alone having a very multiple action. So having a metformin on board gives a very good result in this kind of patients. Next slide. So this is again a very important slide, I would say, key feature of individual therapy. So this is in depth, like metformin having a high efficacy, no hypoglycemia, weight neutral, CV neutral. Also, potential benefits are there in mass. Renal effects neutral and also low cost. DPP4 intermediate efficacy, weight neutral, hypoglycemia, no, CV neutral, renal. We actually require dose adjustment when we use sitagliptin, but cost is high. But now the cost is not an issue, so it is again a very good drug. SGLT2 cost also reduced, having a beneficial renal effect, beneficial CV effect, weight reduction, no hypoglycemia, intermediate to high efficacy. So excellent combination, I would say. Next slide. So decoding the patient persona, as we just discussed about the save him from the comorbidities. So now we always approach not just the glucocentric approach, but we always focus on the cardio renal metabolic approach, where we reduce the cardiac as well as the renal events. So plan the therapy and reduces the comorbidity. That is the main. That should be the main goal of our treating type 2 diabetic patient. Next slide. Yeah, so did I just discuss about all this case, how the things gets better? Yeah. Uh, Again, the same case on this Father's Day. Yeah, type 2 diabetes always come with the comorbidities. So we should always give a proper treatment which reduces the comorbidities as well. Next slide. So yeah, thank you very much for your precious hearing. So if I just summarize the whole talk, these combinations like DPP4 plus SGLT2 or and along with the metformin. So I would say either dual or in a triple drug combinations. These combinations gives a very good result in most type 2 diabetic patients, as it almost addresses the ominous octet of the type 2 diabetic pathogenesis, and also having a very excellent data as the SGLT2 itself having a cardio renal metabolic benefits. And along with the metformin and DPP4, which is a very weight neutral as well as no hypoglycemia, and also metformin having a high efficacy. So the combinations gives a very good reduction in A1C level along with the pleiotropic benefits. So we must, I would say, use these combinations in most of the patients, unless there are some problems or there are some side effects of SGLT2. So there we should avoid. But in the most cases, this combinations is getting well, tolerating well, and giving a very good result. So use it widely. Now the cost also has came down. So I would say use it widely in most cases without any worry. So thank you very much. And if there are any questions, I would happy to address if it is there.
Thank you, sir. Thank you, doctor, and close this.
Yeah, thank you very much. Thank you. Okay.
Hello, shall we end this session here? Hello, am I audible? Hello.